Hi, I'm Dr. Nick Sgaglione. Welcome.
Thank you.
We're here to check your knee today, and obviously we always start by observing how you walk. That gives us a sense if you have any antalgia and your alignment. And then following that, we then observe the knee carefully, and we're going to examine you supine on the examining table. So if you put your head back on the pillow, and I'm going to come around on this side, and the first thing I'm going to do is inspect your entire leg. You would normally have shorts on, so can I roll these up a little bit? And so it's very important to get a sense of the general conditioning of the leg, also the alignment, supine in terms of varus and valgus, a sense of any atrophy of the quadriceps or hamstring or gastroc, and a sense of any swelling. In addition, I'm always going to take your sock off. Is that okay?
Yes.
So that I can look at the entire extremity, including your foot, without any impediment. I see there's not a lot of swelling, and I'm always going to differentiate swelling from actual joint effusion. I'm always going to start by perhaps examining the contralateral normal leg, particularly in the acute setting, to show the patient and show you that there will be confidence gained by our touch, and that we're not going to take a very sore knee and be very rough with it. That said, having done that on the contralateral knee, we'll come to the actual injured knee, and I will look for any point tenderness in the area of the extensor mechanism. So first, retropatellar or patella pain. Does this hurt?
No.
So on retropatellar compression tenderness. Does this hurt over the quad tendon?
No.
Does this hurt over the patella tendon?
A little bit.
A little bit. And then over the tibial tubercle?
No.
Not much. Okay. Now I'm going to ask you to hold your leg up 6 inches off the ground, and this gives us a sense of leg control. It's also a Stinchfield test, which gives us some immediate information about the hip, actually, in terms of the straight leg raising maneuver. And against resistance, push up is the Stinchfield test, and if that produces any pain, we are now also suspicious that something's going on proximally. And I also have the ability to check very carefully, and I'll use a goniometer, whether the patient can get full extension, at least checking from the supine position. Now I'm going to check motion and flexion, so bend your knee up all the way. This can be measured with a goniometer, and this is at about 145 degrees. It also gives you the ability to check the back of the heel to the buttock area, and that distance is about 6 finger lengths. And we can compare this immediately to the left knee. Bend this knee all the way back and get a sense of symmetry, and we can see that there is symmetry related to the injured knee and the contralateral normal knee, both in terms of the goniometric measurement of the knee and as well heel to buttock. Straighten this knee out now. I always tell the patient when we're examining an injured knee to have their left knee flat, because I think it relaxes the pelvis, and so that's important. Sometimes they want to bend this knee, bend it up and bend it back, and you shouldn't examine in this position if you're examining this knee. So straighten that one out. Now I'm going to bring them to 90 degrees, which relax your leg, and I'm going to continue with palpation on the medial joint line for the medial meniscus. Does that hurt there?
No.
And the lateral joint line for the lateral meniscus. Fine. Then I'm going to palpate the MCL off the medial femoral condyle. Is that okay? And the MCL on the tibia. So that's separate from the joint line. To palpate the LCL, I'll go to a figure of 4, and I actually can palpate the LCL as it comes off the fibula head over the joint line, and it's a nice way to be able to examine the LCL for point tenderness. Does that hurt there?
No.
Great. Another area we're going to always palpate is the Pesarine tendon. So this is the joint line. Again, I'm referencing off the inferior pole of the patella for the joint line, and the Pesarine is going to be just medial to the tibial tubercle, which is right here. Is that tender?
No.
It's okay. Good. Lastly, I'm going to palpate the biceps femoris, which is the larger of the hamstring grouping, and 85% of the power comes from the lateral side. The biceps femoris is the largest tendon in the lateral grouping for the hamstrings, and that's non-tender.
No.
And the tib fib joint, this is the fibula, and the fibula head, non-tender there. The iliotibial band I can grab, and you can see it comes in on Gertie's tubercle, and as it comes down, this is the ITB, and as it passes over the lateral from condyle is where some patients will have iliotibial band friction syndrome, particularly the runners. Is that tender there? Great. Now I'm going to do my instability test. While they're at 90, I'll do an anterior draw, and I'll do that in internal rotation and external rotation. Then I will do a Lockman at about, relax, at about 15 degrees for instability. Coming back, I will do a posterior draw and do that in external rotation and internal rotation. I like to examine the MCL in full extension, and you can see, put valgus stress, and then I'll do it in 30 degrees of flexion. Obviously examining for the former, the MCL full and superficial, the deep, and as well the superficial MCL at 30 degrees. Then we'll check varus in extension and varus in 30 degrees. And then I'll finish with some of the tests that are more dynamic. And this is a modified pivot shift test. I abduct the hip to take the actual tension off the iliotibial band. I will externally rotate the tibia. I'll put a valgus stress on the knee, and then gently, as we come in to extension and inflection, see if the patient has a pivot shift. And notice my index finger is over the anterolateral tibial plateau, which will feel the jump as the knee reduces and the tibial plateau reduces with underlying patholaxity if there's an ACL injury. This is not always easy to do in the acute setting. It's seen more with the chronic setting. I always finish my exam by looking at the adjacent joints. I will always check the hip with internal external rotation and compression. And I will always check pulses and see that they have a normal vascular exam in terms of the posterior tibial pulse and the dorsalis pedis pulse. And the final thing is always to get a sense of any neurologic problems. Is there any numbness here?
No.
In the web space? Any numbness here, medial foot?
Nope.
And distally lateral foot, visceral nerve?
Nope.
Push my finger up, EHL, and then EDC, push my finger up, press on the gas, good. And so that in brief is a knee exam. I think it's concise, it's comprehensive, and it gives you the ability to, I think, garner information both in terms of the acute knee injury as well as the chronic knee injury. So thank you very much.
Thank you.